weeks, over 6 weeks, we will have the opportunity to learn about pandemics from a wide variety of perspectives. I look forward to sharing this journey with you. In the audience tonight, we are joined by a variety of students virtually, both incoming and current, as well as alumni, faculty and staff, as well as community members. We are grateful that each and every one of you are here, and we hope that this is a phenomenal experience. At the conclusion of tonight's presentation, Dr. Laws will be answering a few questions. Please note that you will be able to submit questions using the Q&A buttons on your screen. I'd now like to introduce tonight's presenter, Dr. Terri Laws. Dr. Laws is an assistant professor of African and African American Studies and Religious Studies at the University of Michigan-Dearborn. She teaches courses in womanist and Black feminist religious thought, African American religious experience, and medical ethics. Her research examines social and cultural issues in healthcare with an emphasis on African American religion and health inequity. Her publications have appeared in the Journal of Religion and Health, Pastoral Psychology, and Religion and Politics. She has forthcoming essays in Christian Theology and the Modern Sciences, published by T&T Clark, November 2020, and The Religion of White Rage, published by the University of Edinburgh Press, September 2020. Laws received a Doctor of Philosophy in Religion from Rice University in Houston, Texas, a Master of Divinity from the Interdenominational Theological Center in Atlanta, Georgia, and a Bachelor of Business Administration from the University of Cincinnati. During her doctoral studies, Professor Laws completed a bioethics fellowship at the University of Texas MD Anderson Center. I am so great to have Dr. Laws presenting with us tonight. And now I will turn the floor over to her.
Good evening. Thank you so much to the committee, including Dr. Paul Drouse, Dr. Amy Findley, Mr. Scott Riggs, and Andy Beverly. Thanks so much for all of your assistance in getting us here this evening, and let's begin our journey. So tonight I'd like to talk for just a few minutes about inclusiveness in our search for the cure for this current pandemic. So we'll be talking about inclusiveness in the form of race, but please understand that there are other forms of inclusiveness, but we are focusing on race this evening as that is the area of my research. For our agenda this evening, we'd like to begin by giving a little bit of data about Michigan and the United States, the current situation about the pandemic. We're going to do a spoiler alert so that you know very early where we're going in this presentation. We'll do a brief historical presentation on race and ethnicity in medicine and medical research and the disparate experience of race and ethnicity of groups who are raced. We will then do an introduction to the discussion question that I'd like to offer to you so that you can have a conversation with your trusted, that's friends and family who you trust, on your own time. And then of course we will have a quiz that you'll need to do by next week. Our current experience, the Michigan experience as of July 18th, is that we have about 81,338 confirmed and probable cases of COVID-19. In the state of Michigan, we have had approximately, as we understand it, 6,364 confirmed and probable COVID deaths. That gives us a fatality rate of about 8.4%. And again, we're talking about the experience of raced groups. So one of the things that we understand in Michigan is that African Americans are about 14% of the population, and yet have experienced about a 38% disproportionate death. I also want to lift up another area of disproportionate death, and that will help us to understand where we're going on this journey this evening. And that's that we've had 2,005 deaths in long-term care facilities, as well as among residents, as well as staff. And then finally, I'd like to point out, in the United States experience as we currently understand it, that African Americans and Native Americans have been about 5 times more likely than white Americans to be hospitalized with COVID-19. And Latinx persons have been about 4 times more likely to experience hospitalization. So we have, in the experience of race, we want to talk for a few minutes here on this slide. One of the most important pieces of work when we're talking about race and medical research, which is going to be the main focus for us this evening, is a book written by Harriet Washington. Harriet Washington is a journalist and a medical historian and bioethicist. She published in 2006 a book by the name of Medical Apartheid. Of late, you may have begun to hear more about this book. It is 500 pages, and I'm going to give you a spoiler alert because 500 pages is quite a bit. But before we do our spoiler alert, I'm going to talk just a little bit about particular forms of raced medical abuse or medical racism. Washington's text in those 500 pages moves from the colonial experience in the United States to the 20th century. And in doing so, she's writing as a historian. And in writing as a historian, we want to find the documents that support what we understand about the experience of particular groups. In this text then, she has, yes, journals that are written, for example, by physicians at the time, but she also has something unique, and that is that she has the voice of persons who experienced these medical experimentations. And I want to lift out then one particular experience. The experience I'd like to lift out is that of John Brown. John Brown was a man who was enslaved in Georgia during the 19th century. He eventually escaped slavery and lived out the rest of his life in England. In his living out the rest of his life, what he did was to dictate to a writer his lived experience. And in his lived experience, part of what he includes is that he was the subject of a physician's medical experimentation. So the story goes like this, that John Brown was owned by a man named Thomas Stevens. Stevens became ill, and in his becoming ill, Stevens was very grateful to the doctor who eventually helped him toward recovery. To express his gratitude, Dr. Hamilton to express his gratitude, that Mr. Stevens offered to Dr. Hamilton anything that he felt that he could share. And what Hamilton requested was the use of his slave. Now, according to Brown in his memoir, Mr. Stevens did not ask Dr. Hamilton what it was that he wanted with Mr. Brown. And so we're going to pick up here by, if you'll allow me, just to read a little bit of the story from Brown's perspective. Now, it so happened that this Dr. Hamilton had been trying a great number of experiments for the purpose of finding out the best remedies for sunstroke. Remember, they're in Georgia. Hamilton ordered a hole to be dug in the ground, 3.5 feet deep in 3.5 feet deep, 2.5 feet wide, and into this pit, a quantity of dried red oak bark was cast, and fire was set to it. It was allowed to burn until the pit became heated, like an oven. When the embers were taken out, a plank was then put across the bottom of the pit, and on that a stool. Having tested with a thermometer, the precision, listen to the precision, having tested with a thermometer the degree to which the pit was heated, the doctor bade me strip, this is Brown talking, and get in. He did so, and only my head, Brown says, only my head being above the ground. He's in the pit and only his head is above the ground. He then gave me some medicine which he had prepared. And as soon as I was on the stool, a number of wet blankets were fastened over the hole. This was to keep in the heat. It soon began to tell upon me, but though I tried hard to keep up against its effects, in about half an hour I fainted. I was then lifted out and revived, the doctor taking a note of the degree of heat when I left the pit, end quote. Hamilton's goal, Dr. Hamilton's goal, was to sell the concoction that best seemed to revive John. Ultimately, he made a pill of flour, which according to the administration of the drug, had to be dissolved in cayenne pepper tea in order to give the solution. And as we understand from Brown, then Dr. Hamilton sold the concoction and became wealthy from it. Next. So our spoiler alert. One would think that in these 500 pages of horrific histories, such as that which we heard from John Brown, that Harriet Washington would then be saying, African Americans would not and should not participate in medical experimentation. Spoiler alert. She actually says something quite different. So let me read to you the middle of this passage that I've lifted out from the 500 pages. I want to emphasize again the 500 pages, but on page 387, so you always have to read to the end. On page 387, Washington says this: African Americans desperately need the advantages and revelations that only ethical, essentially therapeutic, research initiatives can give them. The reticence or hesitance of African Americans is the reasonable and understandable result of a horrendous history, but it lags behind progress. What Washington wants us to understand is that the history, yes, is real. The racism that has occurred in medicine, the racism that continues to occur in medicine is a real experience. And yet, there's something to be gained, because without participating in medicine fully, without participating in medical research fully, the gaps that occur in health disparity and health inequity cannot be minimized. That's our aim. So that's the rest of the journey that we want to explore for this evening. So let's talk then a little bit about how it is that we got here. So now you've heard the spoiler, you know where we're going. Let's talk a little bit about how we got here. And for that, I'd like to show you a very brief film. Okay, my film seems to be missing. All right, so sorry. Can you see the film? Okay, never mind. I got it. Okay, got it. Here we go. Sound.
Lower right-hand corner of the computer screen.
I can't see it. Is it on? I know it's on here. I just can't see it. Oh, here. Okay. Thank you. No, I think it's not on. I think the sound is not on. You can see the sound? Okay. Please bear with me. No.
My grandmother tells a story of hospitals in her day. One of barriers, one of trauma, one of fear. When we are sick, she pulls remedies from a tattered notebook, recipes passed through generations of those misunderstood by the world around them. She ensures this cold, this ache, this fever will break by morning. All we need is this prayer, this herb, this belief that better days are coming. She doesn't speak of bad health. She says with stern eyes, only speak life, a lesson, a warning, and a hope in one. Packaged words birthed from a time when healthcare didn't look like help for us. I feel this chill down my spine when I am ill, when my only option left is a doctor's office or the never-ending maze of a hospital. The fear that there will be assumptions about who I am, that things will be ignored like culture and beliefs, that I won't be heard, that history repeats itself. Fear that these hallways will be the same broken roads instead of bridges to new understanding. I envy those who don't have to sit with crossed fingers hoping, envy their peace of mind and comfort. All anyone wants is to be understood, to be heard, to be told that help is actually on the way.
Very good. So what you should have heard from the film is that the young woman who is speaking from the experience of her grandmother, which then is becoming her own lived experience. So one wonders often when we're talking about social groups and their culture, how it is that we can say that an experience that meant something to John Brown could mean something to, say, Terri Laws in the 21st century. Culture gets spread from generation to generation. And in that film clip, what we heard was the young woman speaking about not just her own experience, but the experience of those before her. So let us think about John Brown, for example. He shared his memoir. We can read it, but if he had relatives who he shared it with, he would also have been sharing not just his experience, but all of the feelings and distrust that was built up in the reality that Dr. Hamilton was conducting experiments upon him. He'd been lent to the doctor specifically for that. And not only then was he lent, but along came the distrust that was built up from the fact that he used John Brown's body and then concocted flour dipped into cayenne pepper tea, which was supposed to then be a remedy for sunstroke. So we understand then that culture and history and experience all work together. In our understanding then, we can see how health inequity works within race and culture. And so let's go a little bit deeper. Let's find out, for example, what do we mean by race? Race. Race is a series of categories. These categories have been made up by researchers or pseudoscientists, we would refer to them now, starting hundreds of years ago. We call this social construction in that it's been made up, right? And when we say that it's been made up, what we mean is that the categories have some level of flexibility. For example, in 1930, we had a census category in the US called Mexican. We've not used that category since. When we think of the continent of Africa, we generally think of Africans as Black. But in the North African nations, those persons fit into a category that in the US we call white. So this made up or this social construction has some level of flexibility. And one of the things that we should understand is that the category called white is the category that we always want to protect. a second phrase, that we don't just use these categories, but we also want to make sure that we understand that these categories are ranked. Right? And thank you. Okay. I want to make sure you can see what I'm talking about here. Okay, all right. So we've talked about race, we've talked about the ranking, and now we want to talk about the fact that health outcomes are connected to these categories and these ranks. And that some of you will be familiar with the term social determinants of health. And that simply refers to the fact that health outcomes are often related to factors other than just the physical factors. They're related to factors such as education, adequate income, adequate housing, and employment. And one of the things that we've understood during COVID is that the experience of some groups is that we learned that they have less education, less adequate housing, less adequate income. And that matters because, for example, if I'm living in a multi-generational household and I go out and am exposed, and I bring that back to the elder with whom I live, that drives up the exposure possibilities for that elder. And these are, in fact, some of the factors that we have seen. So when we look at that possibility of the young person who may be working in that skilled nursing facility or in that assisted living facility that we talked about a little earlier, that those numbers, those persons who are providing care in that nursing home may in fact then be a person who we would understand may be living with their grandmother, for example. So now the person who's living in the nursing home has been exposed, as well as the grandmother with whom the person lives, with whom the worker lives. Okay. Next, we want to then bring in the idea that we often hear about, which is that biases do occur. Physicians and healthcare providers are part of society. And in part of society, we are accustomed from time to time to having biases. We often refer to these biases as implicit, as in that we're unconscious of them sometimes. And in our being unconscious of them, we may in fact, and in fact this is documented, that persons of color are often undertreated, which then raises the possibility for death. Now, all of this matters during our current pandemic because we want persons, for example, to be tested early enough that they cannot expose someone else. So one of the things that we know that occurred early in the pandemic here in Michigan was that only certain neighborhoods had access. Only persons who had symptoms had access to testing in both of those cases. And in both of those cases then, that allowed the virus to spread into communities that didn't have those kinds of resources assigned to them as of yet. So again, there was overexposure in communities that really needed it most. Okay. And then finally, just a reminder that yes, we have these biases. Yes, they can be unconscious. Okay. And in doing so, we are actually identifying the fact that we have potential dangers associated with entire swaths of persons. And that's what we want you to understand from this last bullet point, that isms, all of the isms, racism, sexism, they actually occur in medicine as they do in other parts of society. So I want to dip back into history then. So now that we have this fuller picture, I want to dip back into history. Just momentarily, quickly run down this list. So we talked about enslaved men, but we also had women. I'll talk a little bit more about that in just a moment. We have the book that I mentioned earlier, Medical Apartheid. These are all of these things are documented in our history. And some of you may, here on campus, may have read last year, The Immortal Life of Henrietta Lacks. We'll talk very briefly about her story as well. And on this list, we have the very famous story of the United States Public Health Service study of untreated syphilis in the Negro male, which we often refer to as Tuskegee or Tuskegee syphilis experiments. And for those of you who had me in medical ethics, you know we go into depth in this, or for those of you who plan to have me in medical ethics. So very quickly, there's a reason why persons of color may be dubious about participating in medical research. We've talked a little bit about the history. I want to give you a couple more examples. And in giving this couple of examples, where I want us to focus this time is, yes, that's the history that influenced the experience or the perspective, but it also helps us to understand why it's important that we then find ways to include all of these communities that may, with reason, based on history and experience, exclude themselves. Ethically, we have the experience of slave women who were also lent for the purpose of developing gynecological surgical techniques. This is a very famous story, becoming very famous, where the person who we refer to as the father of gynecology is known to have had lent slave women available to him in order to perfect the gynecological techniques that were important. But what's important about this ethically is that these enslaved women were used for the refinement. So they, in fact, looking at this picture here, they, in fact, bore the burdens of the gynecological experimentation. But it was white women who ultimately received the benefit. And this is what we're talking about when we're talking about the lack of ethics or ethical problem. We cannot have some groups bear the burdens and other groups bear the benefits. And this is where then the issue of distrust is vital, because we're interconnected in this sense. Very briefly, I'll just give this, hold out this particular bullet point. Puerto Rican women during the late 1950s and 1960s, same kind of issue, that birth control pills very early in development were used in clinical trials. Often the women were volunteering. However, they bore the burden of the side effects in these early trials. And then very quickly, grave robbing. In order to understand medicine, physicians needed bodies on which to train. And it's very well documented, again, that grave robbing in Black cemeteries occurred, and the bodies were then sold, the cadavers were sold to northern medical schools for training. Very quickly, again, the story of Henrietta Lacks. Henrietta Lacks, poor woman living in Maryland. When she went to Johns Hopkins for care, she understood that something was wrong with her body. She ended up at Johns Hopkins, where they provided charity care. We would think that this was good. But in providing charity care, one of the perspectives of some of the physicians was that in exchange for this care, that persons who were at Hopkins in charity care would then be accessible to researchers for whatever was needed with their bodies. And in this particular case, tissues were taken from Henrietta Lacks. It was learned later that her cells would continue to duplicate. And in the duplication, these cells were then used for medical discoveries and have been and continue to be used for medical discoveries for decades now. She died in the 1950s. And yet, her family line continues often to live without compensation and without health insurance in some cases. It certainly was true at the time of the writing of the text. So let's just say that instead of all of these negative stories that we've had so far in the history, these real stories, right, that there was in fact, let's just suggest that if we could think about healthcare and medical research in a different way, if we could think about African Americans and other people of color as being full participants or fuller participants, how might then that impact us in as we try to move forward during this age of COVID-19? So I'd like to offer something to think about. Henrietta Lacks' cells needed to be mass produced. As we began to understand their value to medical science, they needed to be mass produced. And in that need for mass production, we actually have documentation that Tuskegee University, we now call it Tuskegee University, a historically Black university, is in fact the place where HeLa cells were first mass produced. So if we were able to think about Tuskegee in terms of the science that it contributes, we would not only be having a conversation about Tuskegee as a place where victimhood occurred. And this is a reminder that we in fact do have both of these histories with which we must wrestle. On this particular slide, I want to point out a couple of things. I want to point out that here, recruitment and treatment of the men who were untreated occurred through Black institutions. We'll hold that out for a second. The person who was able to keep up with all of these men over the course of 40 years, Tuskegee, this study went on for 40 years, was a trusted member of the community, Black nurse. Okay? But we also want to point out that one of the persons who became a truth teller who worked for the CDC and understood or became aware of the experimentation, the unethical experimentation that went on, was Dr. Bill Jenkins. He's an epidemiologist. He died just in the last couple of years, and he was one of the first people on the inside of the CDC who brought awareness to its problems. So with this slide, we have a fuller picture of African American participation. We have African Americans as researchers, we have African Americans as patients or subjects, really, in this case, because part of the problem that we must understand is that the men were participating because they were not told the truth. They did not know that they were participating in an experiment. So once again, we're able to see a fuller picture, but we're also able to see some of the mechanisms that unfortunately have been used as a mechanism for sustaining distrust, for developing and sustaining distrust. Over the course of probably 120 years, have we formally been studying health disparity, medical racism, especially as it relates to medical research. 120 years. But recall that earlier slide, this idea of race has been around for 400 years. So these are two pieces of the puzzle that we're struggling with. And when I say struggle, we have this idea of vulnerable persons, but we also have this idea that exploitation can occur in medical racism or in medical research. And in this idea of exploitation, what we understand, think back to John Brown and Dr. Hamilton, think back to Henrietta Lacks. In experimentation, what we want to avoid is exploitation. Everyone wants to avoid exploitation. People of color, whites, everyone. No one wants to be identified as a guinea pig, or in our formal language, vulnerable persons. So the question then becomes, is it possible for us to move forward given this history of harms that we've been discussing? Very quickly, I want to give you the overview for those of you who haven't taken medical ethics yet, give you an overview of where we focus. Autonomy is the idea in bioethical reasoning that my body is my own and I get to decide whether I participate in medical research. Beneficence, medical research should never be for anything other than a specific purpose with medical value. Non-maleficence, we don't want medical research to harm anyone, at least not intentionally. And justice, that we want to be sure that medical research is fair. Think back to when I described about testing and where it was available and who was available to. We want fairness in medical research, that the risks of medical research ought not be assigned to one group and that the benefits be assigned to another group. So morally, in order to do that, we want to avoid exploitation, that risk-benefit sharing, right? We want to treat the most in need as resources are available. Think back to the testing example. And then we get in a little bit deeper, which we won't do tonight. This is where I want you to begin to think with your friends and family about our future moving forward. When we say most in need, that's a tricky concept. Do we mean first responders? Do we mean the sickest patients? Do we mean populations that are most at risk? Do we mean first come, first serve? Whoever gets to the hospital first gets the treatment first. Very quickly, we have African Americans participate in medical research. Want to be clear, because remember, think back to Harriet Washington. She said, and here's her quote again, but focus on a slightly different part of it than before. This time we're focused on the part that says aversion to clinical trials is at peril. And being at peril, what we want to do again is follow those ethical ideas that we just talked about on the previous slide. Right? But one of the things that we have to understand is that it isn't just a matter of participating in the clinical trials, it's a matter then of being able to follow through with the treatments or vaccinations that come out of clinical trials. And one of the things that we know is that African Americans actually end up being in trials that don't require consent more often. So we want to be sure that we understand that. And just very quickly, we know that we have an anti-vax community, persons who, for whatever reasons, are concerned about participating in receiving vaccinations. And at this point, we do know that there's some concern about that approximately 70% of whites have suggested that when a vaccine becomes available, that they will in fact participate. But about 63% of Black adults have said that. So we have some gap there as well. So that was the worst case scenario. that we have persons who are participating without trust, or who won't participate because they don't trust. But here we also have a best case scenario. On this slide, you see me, but of course you also see Kim. Kim is a best case scenario. Kim is an African American who did in fact participate in clinical trials. We know that because Kim is one of my oldest friends. I met her when we were in elementary school. This is us at the University of Cincinnati homecoming several years ago. And Kim, being a good friend, one of those sister friends, all of us have friends like this, that you don't talk to them for a few years, but when you get together, you talk for hours upon hours. My last conversation with Kim was June 23rd, 2018. I went to visit her at her home in Florida. And Kim and I got to catching up. And in our catching up, she lent to me a couple of blue folders. We were talking about some of my research, and she lent me a couple of blue folders. She said, "I'll give you these blue folders if it will help your research." What was in those blue folders were 2 clinical trials that Kim had been trying to get into. So she had given her consent, and she was just waiting to find out if she would be selected. Unfortunately, Kim had metastatic breast cancer and died 2 weeks later. But I never forgot what she said to me. What she said to me was, "If it will help, here are these 2 blue folders." And with me this evening, I have those 2 blue folders. Those folders have kept me to doing this work, because a story like Kim's is a story that we also have to lift up. Kim's story is very simply this. Yes, she had metastatic breast cancer, but she also wanted desperately to participate in clinical trials. But we should understand something very specific, and the research shows this, that Kim was an educated woman. She was a healthcare insurance executive, and she had a great resources and sufficient income, including a beautiful 5-bedroom house. She fits the profile of people who very typically participate in cancer clinical trials. They have options. And that's what we want to make sure that we don't overlook. We don't want to overlook that people are willing to participate. The research shows this as well. African Americans are willing to participate, but we must have transparency, and we must realize that it is important. The NIH understands this, that it is vital that we have persons across racial lines participating in order for us to defeat COVID. So, quick takeaways. If you're interested in participating in medical research during our current crisis, one of the things that you should do is make sure that you're having a conversation with your family and your loved ones before you get into crisis. Make sure that you explain that you're willing to participate, if in fact that's the case for you. Remember, research itself is not actually to try to cure you right now, but it is because you're participating because you want there to be future possibilities for others. We want to make sure that you're participating in phase 3 trials. By the time it gets to phase 3, that's more therapeutic. Some people will be willing to participate earlier, and to be sure that you understand that consent is your right, and that you can, in fact, end participation at your leisure. At any time you're feeling uncomfortable. And then finally, I want to leave this discussion question with you. What if you have now understood the history of people of color and African Americans in medical research and medicine. What if now then you yourself want to think about how do we move forward in developing a system that is more inclusive? Commercial break, be sure to take medical ethics. Any of my courses are available, right? And finally, here are some resources for you. Thank you so much for your time and attention. And I'm happy for questions.
Okay. Thank you so much, Dr. Laws, for that thought-provoking presentation. And so with the conclusion of your remarks, we will now move into the question and answer period. And I just want to remind everyone that on the bottom of your screen, there is a Q&A button that allows you to submit questions live to us. We'll try to get to as many questions as we can. Some questions have already been submitted. So our first question, Dr. Laws, do they still have healthcare trials without consent in any state in the United States?
Unfortunately, there are trials without consent. And that was the slide that I went through very quickly, that there are trials. EFIC was gosh, I can't think of the letters right now, but it's without informed consent. And it very often happens in emergency situations like the pandemic that we are experiencing right now. And there is overexposure for persons of color in those trials. So yes, that's why you want to have the conversation now before you're in a crisis.
Okay, thank you. Our next question. So in your presentation, you observed that the idea of race is hundreds of years old, and that academics have been studying health differences between Blacks and whites for over a century. In addition to greater participation in clinical research by African Americans and other people of color, what is something else that might contribute to our understanding? Really, so we know that this has been studied for hundreds of years. This is how I'm reading this question, right? Or we know it's existed for hundreds of years, but only been studied for about 100 years. So in addition to greater participation in clinical research by people of color and other African Americans, what other things can we think about in this context that might contribute to our understanding overall?
Thank you. One of the things that we should understand is that we are actually fortunate here in Michigan in that we actually collect race, because we are not actually clear for across the country that race is collected. So we don't know, so that leaves us then that we don't know what we don't know. But because we know in the state of Michigan, we are actually able then to set up a task force to identify the reasons for these gaps, and that we could then go about attempting to solve it. So that's one of the things that we should understand. And we should also understand that we work through institutions. I mentioned this very quickly, that we work through institutions, through community institutions. So in our community, we know that if we want to work with the Arab American community, we go to Access, right? We know that in the African American community, we go to churches, right? But we should also understand that the researchers in Tuskegee also understood that, right? So so we as researchers have to be thinking about, how do we build rapport, right? Race can be distrustful, but we have to be thinking about, how do we build rapport before we actually need the community.
Fantastic, thank you. Next question. If I want to participate in clinical trials, but so far I'm healthy and without any health problems, do you recommend this? And if so, how do I try to find studies to participate in?
Yes, so actually there are, normally there is clinicaltrials.gov, but for COVID, there actually are clinical trial websites in and of itself just for COVID. So yes, you can participate as a healthy person. in healthy persons, we especially want to participate in these earlier trials, the phase 1 and phase 2, where it's first in humans. Phase 3 is, I always emphasize phase 3, especially for persons who perhaps want to help, but maybe a little more distrustful. But we know, for example, these announcements that we're getting now are from trials that are from healthy participants. That the vaccine trials that we hear about, for example, yesterday in the Oxford trials, these are typically healthy participants. So clinicaltrials.gov and coronavirus, look for coronavirus, and CDC also has lots of information about how to find a trial.
Excellent, thank you. So 2 questions came in that really dovetail nicely together. So the first is, can you talk a little bit about how those going in the medical field can try to defeat their own implicit bias? And to dovetail with that, I would add, and can you please discuss the benefits and limitations of implicit bias training?
So first, I provided some resources, but we have, as a campus, we're very fortunate that last year we had for our community read, The Immortal Life of Henrietta Lacks. I mentioned medical apartheid. Reading is always an excellent way to get a fuller explanation. In this year, I believe it's already been announced that we're going to be, for community read, going to be reading How to Be an Anti-Racist, right? So this helps us to understand these systems. Remember that slide said that all of these work through systems. We're talking about systems here. We're not talking about individuals. Now, when we're talking about individuals, yes, we are talking about implicit bias. But we should understand a couple of things about implicit bias. First of all, it works worst in stressful situations, right? That's when it comes out most, and most vehemently. But we should understand, for example, let me say, if in the best case scenario, that question came from a student, right? And so coming from a student, we have African American studies, we have women and gender studies, we have Arab American studies. We must educate ourselves. We cannot only live on our own experience. So reading, yes, experiencing, getting to know, but finally implicit bias works because often there's some kind of fear at play. Okay, so there's stress and there's fear. We have to be aware of ourselves. And that is not to say that the implicit bias goes away, but we can train ourselves to not respond to whatever is bringing up that bias.
Excellent, thank you. So do you know that as of yet, has COVID-19 research changed once the disparate impact was recognized by the medical community or the research community?
This is actually one of the things that we're, again, because we're not collecting race everywhere, we're actually not sure. Right? What we are identifying, we are beginning to identify are some of the other problems that go along though with distrust. For example, my mentioning of anti-vaccination. Right? This occurs in all communities. Okay? It occurs in African American communities. And there was a story, just maybe 3 or 4 days ago in Washington Post. So what we're beginning to do is to identify some of the other problems even before we have the data, because the problems have pre-existed coronavirus. So now we're beginning to understand some of the other problems that exist in that gap and in our implicit bias.
So the next question is about the population of folks that are in prison. So much research is done on prisoners who are not truly free to accept and who are disproportionately Black men and women. Doesn't that automatically create an exploitative situation?
Yes, it can. Yes, it absolutely can. Yeah. Prisoners, even though I didn't focus on that, that is another part of the horrendous history Right? Prisoners have, it is well known that prisoners participate in research because they believe they might get some special privileges. So yes, that was in fact exploitative, and no, we cannot presume by any stretch that that exploitative example no longer exists. We must presume that all of the things in history that have been exploitative continue to exist, which means that we have to then educate ourselves so that we can be vigilant to identify it.
So could you describe how this implicit bias might appear in veterinary practice?
So let's just, so the first example that, and I'm not a pet owner, but the first thing that comes to mind is, let's just say that a pet owner brings in his or her pet, a dog. Let's just say that the dog has a broken leg, and the owner says to the dog, or says to the veterinarian, that the dog was hit by a car. The veterinarian looks in disbelief at the owner and accuses the owner of misuse of that animal. Okay? This is implicit bias at work. It's implicit bias at work because the veterinarian is dismissing what the owner has said and presuming that there's been some kind of wrong behavior. This is quite typical, both in human medicine as well as other forms of medicine.
Okay, thank you. Our next question. I work closely with ophthalmologists where glaucoma diagnoses are common, but many physicians are taught to look for glaucoma as a vision issue in African Americans because it has been shown to have a higher prevalence in the African American community. At what point are assumptions of certain medical illnesses racism? And at what point are they research topics that require testing that one race may receive over another?
This is a really good question, right? Because we do not have to presume that something nefarious is at play. So I want to speak to that using an example that I use in class all the time. The example that I use in class all the time is that I go back to the Tuskegee experiment, because we're also familiar with that. If you're not familiar with it, just send me an email and I'll explain it. But in that, I ask students, is it automatically problematic that we design a treatment for a group that has a particular problem? The answer, of course, is no. If there's an intervention, a public health intervention needed for a particular group, as is described in the question, what's ethical is to address that problem. That is what is ethical. What is unethical is to assign nefarious reasons to the disease at hand, or to presume that there's something biologically inferior about the group that continues to that has a greater incidence. That's the difference between medical racism versus public health treatment. Right? You want to provide care. We don't need to moralize. As a religious studies scholar, we don't have to moralize disease in order to treat it.
Thank you. So a couple of questions have come in with sort of similar themes. So what do people of color do, or what should they do when they feel like they are encountering some version of implicit bias in the medical field or otherwise?
So here, anecdotally, I'll talk about COVID here. Anecdotally, we are beginning to hear that African Americans are speaking up more in their physician's visits. There's plenty of data to show that oftentimes caregivers in implicit bias speak to persons of color and women, rather than ask questions of them. But in order to be a good patient, and actually, Health and Human Services, the federal agency, Health and Human Services, I believe it is, has a how-to guide for how to be a good patient, right? Come with your questions, prepare for your visit, know what you want to know, and don't leave until you find out what you want to know. So there actually are public health guides that help, that instruct us about how to be a good patient. Speaking up, even in the concern, even having the concern that you will be treated, not be treated, that's because that's the issue at hand, is a power dynamic. But speaking up or speaking to someone else who can speak on one's behalf. In hospital, for example, there's a patient advocate or a social worker who you might speak to, who may speak to that physician on the patient's behalf. So there are other professionals on the healthcare team who are willing to help patients with that.
So this question is about participation in studies related to the pandemic. So are there current studies that you're familiar with that you would encourage folks watching this and participating in this course to get involved with?
Not specifically. I know there have been some studies at Henry Ford. I did not bring with me a list, sorry, this evening, but for certain, there is medicine being created here in our area. And if that person is not in our area, they're happening around the country. So again, look at clinicaltrials.gov or coronavirus, I believe it's .org. And check the CDC website for specific studies. I'm sorry I didn't bring a specific study in mind.
So what protections are there for participants in a clinical research study?
Another great question. Okay, so I think, is my screen still, am I still, yes, okay, great. So I want to go back to, I'll go back to this one, because here in this slide, what I wanted to do was to talk a little bit about protections, right? So when I talked here about these are things that tell us whether things are ethical. These are just an overview that gives us a guide about ethics of medical research. But here is where I want to do my own decision making. I want to think about whether or not I'm ready to participate. And I want to have that conversation with my loved ones. I want to ask myself, why am I doing this? Do I want to help? Am I seeking treatment? And understand the difference between treatment and research. Research can provide benefit, but it doesn't always, and that really isn't its design. When I'm making decisions about what's moral for me, just looking back again to the other set of principles, autonomy and justice, where do I get my sense of moral decision making? Is it out of my intellect? Is it out of my religion, which is true for many African Americans? Is it out of some other kinds of beliefs? Is it out of me? I believe I have the will to do this. Am I doing this because I'm a lover of justice? Am I doing this because I think it might help me, right? So I want to gain access to novel treatments. Because remember what Washington said way back in one of those earlier slides. She said that we can ill afford to not have everyone participating. And then what level of risk am I willing to take? Am I willing to, going back to the question from the person who asked about being a healthy person. Am I healthy so I'm willing to risk phase 1 where this drug has never been used in a human before? Am I willing to risk phase 2 where I'm willing to risk what kinds of side effects may in fact be induced? Or am I looking for something that may be more therapeutic? And always remember that I'm a volunteer. And because I'm a volunteer, I may withdraw my consent at any time. That is one's right as a participant. I may withdraw my consent at any time. The researcher won't be happy. That's not your problem. The researcher, that's the researcher's problem.
Okay, so that brings me to an interesting question, which is there any type of punishment for trials that are done without consent?
Yes. The punishment can be to the individual researcher, but the punishment can also be to that researcher's institution. And we have had well-named or very famous institutions lose access to medical research dollars through that particular researcher to the tune of millions of dollars. So it isn't just a researcher's not risking only their own research, they're risking the research of other persons in their institution. We would not want the entire University of Michigan system to be without access to federal research dollars. And we have to take our clinical, our testing, we have to make sure that we're certified in our research capabilities every few years. And in fact, I think a new one is coming out soon.
So this is our last question for the evening. As you stated, HeLa cells were taken without consent and should not have been done. So we're thinking about last year's common read, The Immortal Life of Henrietta Lacks. However, what would you say to people who say that although it should never have happened, her cells brought in a new era of change and helped to battle cancer and other diseases and saved lives that would otherwise have been lost?
We're talking about a science as though we can divorce it from its ethics. We never want to divorce science from its ethics. Yes, we always want to celebrate discoveries, and we want to celebrate those discoveries that have been particularly helpful, right? Because they've been helpful for everyone. But we cannot overlook destruction or things that were done unethically because they come at a cost, right? This whole conversation has I've included the word distrust and mistrust many times. So when we're thinking about, yes, we could get something beneficial, it is true, but those benefits come at the risk of medicine as an enterprise. And especially, I want to go back to COVID, especially during this time when we are reliant upon one another. We're reliant on someone to wear their mask, right? We're reliant, we are showing, we're learning, not showing, perhaps for some, learning for others, that we are interconnected. And we want to do the same thing with this idea of medical discovery and the ethics of medical discovery. We don't want to divorce the two.
Okay, so that concludes the formal part of tonight's presentation and question and answer. I'd now like to just spend a quick moment going over some brief housekeeping details. But before we do that, I'd like to say a thank you to Dr. Laws for an amazing presentation this evening. So let's talk a little bit about things you need to know about to participate in our series. The link that you use to access tonight's presentation will be the link that you use each and every week to access our course. All presentations are being recorded, so tonight's presentation will be available probably tomorrow on the Pandemics Perspectives website. Students who are enrolled for this course for a credit, please know that you should already have access to the Canvas site. The course is listed as Libs 290. If you do not see the Canvas site by tomorrow and you've signed up for the course with credit, please email pandemicperspectives@umich.edu as soon as possible so we can identify what the issue is and get it resolved. In the Canvas site, students taking this for credit will find a 5-question quiz. That quiz should be live now. please be sure to take the quiz no later than next Monday, 7/27 at 11:59 p.m. As a reminder, to earn the credit, you must participate in the sessions, complete the quizzes, and then complete the reflection assignment, which will be given at the end of our 6 weeks together. Lastly, I just want to invite all of you who are here this evening to be sure to join us next week when we have Drs. Paul Draus and Dr. Jacob Napierowski here. It's going to be a very exciting presentation about the history of a pandemic of cholera in London. So please do join us. It has been my pleasure to be here with you this evening, and I look forward to seeing you next week. Good night.